Thank you everyone for joining. I think on this platform we can see you by we've had about 220 people sign up, and I can already see that 40 of you are here. We're going to give it a few more minutes so others can join, and I'll do a short introduction. All right, I can see more people are joining. Okay, let's get going. Thank you for finding the time this morning or evening if you're calling from Europe. And if you haven't met Dr. Joseph Raffaele before, this is certainly somebody you should know in the space. He has one of the oldest running longevity practices in New York. I think it's now 27 years, if not more. And apart from being a lovely doctor, because some of his patients are in the 90s and have been seeing him for over 25 years, he's a great scientist, a physician scientist in the background. He started in the aging biology space as one of the first, from telomere biology to epigenetics, and now is venturing into glycomics. And working together with him, I think we've found beyond just using this tool in practice, I think we've had some very important discoveries. And I was going to share two slides quickly, and I'll leave it to Joseph to take you through his talk. But I think all of us now, there's a lot of hype in the space, and the industry is looking for the next billion-dollar longevity drug. And I think what we're trying to kind of indicate today is that that drug is potentially already here. And it's related to estrogen. And it's not just in the case of women, it's also potentially in the case of men. But for women, because HRT has been in practice for 50 to 60 years now, we do have the long-term data on its effect on all-cause mortality. And if started early in menopause, it's associated with a 40% reduction in all-cause mortality. But despite having so much historical data and validation, unfortunately, it's not really used much in practice. Only about 4% of women globally are on estrogen. And again, this data just exists for women, and it's potentially also relevant to men. So we just published a study a few months ago with Joseph around testosterone. So we're going to start with a whole picture story around estrogen and then end it on men and how this relates to supporting men. Dr. Joe, we leave it to you. You can share screen.
Thank you very much, Nina. That was a great introduction. Put us in context in 2025. Let me just share my screen. Can you see the slide?
Yes, we can.
Okay, great. So that's where we are in 2025. And my question that I'm going to address is, does HRT really slow the aging process? That is it a longevity therapeutic, a geroprotector? And I'm going to give you some new perspective from 2025. Okay, let's advance. Second, it's not advancing. Huh. Why isn't it advancing? Okay, let's try that. Oh, sorry about that. Okay. All right, so HRT has been around for a long time, since the late 50s in the US. And this book that was published in 1966 by Robert Wilson, Feminine Forever, has sort of really kicked it off, showing that women could continue to have a healthy life. And he focused a little bit too much and politically incorrectly in 2025 on there being sexual beings later into life. But it really started the whole process of women, so that by the time 2002 came around, when the Women's Health Initiative was just about to be published, over 40% of American women were taking HRT. But then, as we all know, in 2002, the study came out, a very flawed study, even a more flawed interpretation of it. And all of a sudden, prescriptions for HRT dropped in the US precipitously and around the world. And the story continued. Books came out about the estrogen dilemma. Is it good for you? Is it bad for you? But I think that, by the time 2023 came around, it really had come back around 180 degrees. We understood from reinterpreting the Women's Health Initiative that the timing hypothesis showed us that the study really did actually show us that in women going through menopause, it did exactly what we thought it did for the previous 50 years. But if you look at them in their 60s and 70s, you have to do it a little bit more carefully. And unfortunately, though, it still hasn't completely filtered down that hormone therapy is really safe and effective. And I think, as I'm going to show you, hopefully, really should be thought of as longevity medicine. That brings us to current day ways of thinking about longevity. And there's something called the geroscience hypothesis. And that is that even if you cure cancer or cardiovascular disease or any of the major killers, you're only going to get a few years of overall increase in life expectancy. That's because it's sort of like whack-a-mole. You cure one disease and you stay alive a little longer, the next disease comes along and kills you. So the hypothesis says that treating fundamental processes of aging, you can potentially double life expectancy as has been shown in many animal models, worms, flies, laboratory mice. And this has been done in the interventions testing program at the National Institutes of Aging, where they've looked at many compounds, some you're familiar with, rapamycin, SGLT2 inhibitors, metformin, and 17-alpha estradiol, which is different from 17-beta, which is what's used in HRT, but that has been shown also to extend longevity in mice, in male mice. So I think that if you think about the process of aging, you really have to think of it in the context of the hallmarks of aging. This paper from 2013 that was then updated in 2022, which first introduced the 9 hallmarks of aging, but then added 5 other ones, is really the sort of framework that we think about the various types of aging that take place as we get older. And I won't go through each one of them, but show you that one of the major additions is inflammation. And we all know that inflammation is part of the aging process, not just the inflammation that occurs with infections, but it's really more this sterile inflammation that is chronic and low grade, that is caused by senescent cells and oxidative stress and other endogenous processes, in addition to latent viruses that accelerates the aging process. So it's a major target, and it's actually got a name called inflammaging. But how do we know if we're really targeting inflammaging? Well, what gets measured gets managed. So how have we been managing inflammation? We've been looking at hsCRP, TNF-alpha, IL-6, the SED rate, the neutrophil to lymphocyte ratio, other markers. But the problems with these is that they have some disadvantages. They can be skewed when there's acute infection. They're not actually a really good measure of this chronic sterile inflammaging. This is where the new kid on the block, glycans, comes along. And that's what I'm going to be talking about. What are glycans? I think you need a little bit of an introduction. Those of you who know about glycans, just hold on for a sec. We're going to get to some really interesting stuff. Glycans are what has been called by Gordon Louse, the premier glycobiologist in the world, the third revolution in evolution. You have DNA getting transcribed into RNA that's translated into proteins, and that's where we thought it ended. But the essential dogma really continues in the proteins and actually lipids and other biomolecules getting altered by the addition of glycans to them. That's these blue stuff and green stuff's attached to this molecule here with the other under skeleton of it. They are complex oligosaccharides, which are consisting of 5 main non-glucose sugars. This really enabled multicellular life and non-genetic response to the environment. And that allowed for a much more complex response to your environment that didn't have to be at the level of the DNA and RNA. All cells of organisms have glycans attached to them. So it's really part of all of biology. You may think that you're not familiar with glycans, but the ABO blood groups are glycans. That's how they determine what blood type you are. What sugars are attached to your blood groups, to your red blood cells. And then if you think about the endothelium glycocalyx is composed of glycans. And when that starts to get eroded, your arteries are not nearly as healthy as they are when it's fully intact. So that's what glycans are. They are complex oligosaccharides. It's a process of glycosylation, enzymatically attaching proteins to form glycoproteins post-translationally. It regulates the function of proteins. For example, in a monoclonal antibody, to change its affinity, changes in glycosylation can effectuate that. What they are not, and your patients will often ask you about this, glycans, you're talking about hemoglobin A1C. That's not what they are. They are not free sugars attached to proteins in random non-enzymatic reactions that damage protein function, like A1C. They are very much important signaling molecules. Currently, not the whole glycoproteome can be characterized. So we mostly look just at the IgG antibodies right now, clinically. And that's what I'm going to be talking about. So IgG glycosylation, that is when this beautiful sort of antenna-like tree of glycans composed of N-acetylglucosamine, mannose, galactose, N-acetylneurominic acid, and fucose get attached at the asparagine right here on the constant part of the antibody. It is also gets attached to the variable component, but that's less important in overall glycan function. And it's this down on this Fc part of the receptor where it gets attached to other parts of the immune system to start an immune signaling response. Glycans can be or anti-inflammatory, and it's really dependent on this structure of the glycan. When it is missing galactose, it's these yellow things here attached to these other molecules, it starts to become more inflammatory. A young, youthful, very healthy one has 2 galactoses and actually 2 sialic acids attached to it, fucose attached to it. And as you lose components of these antennae, you become more inflammatory, going from G2 to G1 to G0. And that's because the affinity for the Fc receptor is increased as you lose these parts of the antenna. And this is just how they do it. It's ultra high throughput liquid chromatography. And there's various peaks that they look at, and they've got this really all very well worked out with these 5 oligosaccharides, these 5 sugars attached to create this big oligosaccharide. So that's a brief introduction to the structure of glycans and what they do. What impacts the IgG glycome? Well, pretty much everything. Whether you're a smoker, lifestyle, diet, other environmental factors, antigen load, meaning what kinds of infections you have, viral, fungal, bacterial, whether you exercise, what medications you're on, what's your immunization context. All of these things are integrated into determining what your pattern of glycans, sugars are going to be on your glycans. How does this occur? Well, glycans integrate the genetic, the epigenetic, and environmental inputs. You get direct physiological effects on it. It can happen through epigenetics. It can happen if you have certain SNPs. This is because you have these glycosyl transferases that put on different sugar patterns depending on whether they're turned on or turned off. So it's really that 4th signaling mechanism that can be impacted by both your genetics, your epigenetics, and direct environmental challenges. I'm not going to talk about this in detail, but the way in which your IgG glycome is regulated is very complex. This is a genome-wide association study showing all the different genes and the interactions in them in various inflammatory diseases that determine your glycome. And so it's a very complicated process that is still being worked out in many ways, but it shows how integral it is to the functioning of of human biology, and particularly the immune system. There's also a disease association. This is from a paper that came out in 2023 that showed all the diseases that changes in the IgG glycome are associated with, going from G0 to G1 to G2 to S. If you have varying changes in your IgG glycome, you can be at increased risk for any one of these diseases, from cancer to autoimmune disorders, cardiovascular disease disorders, But I want to point out in particular this area here that we're going to talk about where menopause and perimenopause sit, and going to talk more in detail about that. But this, I think, should impress upon you the fact that virtually every aspect of sort of many diseases of aging are impacted by what type of IgG glycone you have. And in fact, GlycanAge is looking at predicting diseases with changes in patterns in your IgG glycone. And this shows what happens with age. In this study, it looked at changes in these different peaks in the IgG glycone, the GP4, GP6, GP14. Some go up with age, some go down with age. But because of that, you can predict what your IgG glycan pattern is for a particular age. And that's exactly what was done to create the GlycanAge. You see here that it's a very good biomarker of aging. If you look at these three glycans, 6, 14, and 15, you can get an R squared with chronological age of about 0.58, which makes for a very good biomarker. Remember, you don't want an R squared of 0.99 because that's just the same as age. It doesn't give you any extra information. Where you are above and below this line that bisects the square here really gives you information about how you're aging. There's different formulas for males and females. It's 40% heritable, but fully 60% of it is from lifestyle, diet, exercise, stress, fitness level, and hormones are a major part of it, particularly estradiol. It's highly predictive of disease and responsive to interventions. This is a editorial just basically asking the questions, are glycans the holy grail for biomarkers of aging? And I think in some ways they are. There's no single biomarkers, as any of you who have heard me speak know, that can function for everything, but it is predictive, it's responsive, it's stable. And so looking at glycans, I think, because they are such a great indicator of inflammation, I agree with this, that it is a very, very good biomarker of aging. So let's look at menopause. What happens during menopause? Well, there's an accelerated change in the IgG glycone during perimenopause, where there's an increase in these agalactosylated glycans. That's a mouthful, but that's the ones that don't have any galactose attached to them and therefore are more inflammatory. And there's a decrease in the ones that do have galactoses, mono and digalactosylated glycans that are anti-inflammatory. And so you see this accelerated increase over the course of perimenopause into menopause, with loss of the yellow ones that sit on top of this little antenna structure here to make them more inflammatory. Increase in inflammation is caused by these increase in the agalactosylated one, and the less inflammatory effect occurs because of the decrease in the mono and digalactosylated ones. And this just shows one woman as she goes through perimenopause who was very fit, very healthy, had good estrogen levels, was functioning like a 28 to 29-year-old, and then she goes through perimenopause and she jumps up to a 58. Well, that's a more extreme example, but what happened was she was up there and then looks like she got treated with estrogen finally at age 52. Now that's all well and good, but how do we really know that it's the estrogen? Well, this is a really great study done by Jurek et al. It looked at 36 premenopausal women. So you want to separate it out from just the aging process itself. Is it really estrogen? So they took healthy young women, average age 39, suppressed their estradiol with GnRH, and then added back estradiol through a patch at a pretty good dose, 0.075. Those of you who do HRT know that that's in the upper end of the range of therapy. So they got a good estrogen level back to good levels. And what happened was, over 5 months, so they did that, and then they let them recover and recover normal menstrual function over 4 months. There was 21 in the placebo group and 15 in the estrogen add-back group. So this is what happened. There was, in the group that took placebo, there was an increase in their GlycanAge, quite significantly, 28 or 29% or so. But in the intervention group, there was no increase at all. In other words, when you added back estradiol, the GlycanAge did not go up, whereas it went up 9 years in the placebo group. And then they both recovered, although the placebo group didn't fully recover. The other group stayed in good range. So that demonstrated that it's really the loss of estrogen, particularly estradiol, that takes place during perimenopause and menopause that causes the increase in GlycanAge. A 9.1-year increase, as I mentioned, nothing happened on the patch. So how is this in real life in your practices, or if you're a patient watching, what's happening with your GlycanAge? Well, here's a 56-year-old woman, 6 years since her last menstrual period, in other words, in menopause, and she was HRT naive. She had severe depression, fatigue, weight gain. And so I started her on estradiol, transdermal patch, testosterone cream, oral DHEA, progesterone, all of which can add to things as well, but it's primarily the transdermal estradiol. And then in the first 3 months, we got a reduction of 8 years in her GlycanAge, going from 73 to 65, and then subsequently to 11-year reduction at 1 year. And if we were continuing to follow along, we would probably see a further reduction. Here is a 56-year-old woman who's 4 years since menopause, but came in on oral estradiol and progesterone at bedtime. She was extremely fit, metabolically in excellent shape, exercised regularly, had a great diet. She had some sleep issues, some joint aches, some vaginal dryness. She was on HRT. She didn't have vasomotor symptoms, but it wasn't probably fully adequate HRT. So I switched her over to cream and increased her estradiol gradually. And you can see here that she had a decrease of 10 years, and then a little bit of a backtracking here, and then she went back down to 10 years again, with an increase from the low 30s in her estradiol level and picograms per ml up to ultimately 74, which helped to improve her GlycanAge. So I do that, and I'll talk about that a little bit later, that you want to get that GlycanAge down, and sometimes even when symptoms are gone, adding a little bit more estrogen, as long as there's no symptoms of excess, can help improve the GlycanAge, and I think overall aging because of that. So what about men? Does this occur in men? Is the whole beneficial effect of estradiol in women? Well, I alluded to the fact that in the interventions testing program, 17-alpha estradiol seemed to be a very good geroprotector in male mice. So do estrogen regulate IgG glycosylation in men? Here's a nice study by Erkan et al. Looking at younger men, 20 to 50 years of age, to see the effects of testosterone and estradiol on sexual function, muscle, fat, both sub-Q and visceral. And what they did was similar to the other study that I showed you, in which the GnRH knocked out estradiol. Goserelin does the same things in males. It knocks out the gonadotropins. And then they gave back testosterone at 1.25, 2.5, 5, and 10. The lower 1.25 and 2.5 are being sort of lower replacement doses of the testosterone gel. And this is what happened. You saw at 12 weeks a reduction in testosterone down to almost nothing. But when you gave add back, you had the testosterone levels maintained. This wide spread here is because it went from probably inadequate dosing to mildly adequate to then very good at 10 grams. The estradiol level dropped along with that, but then also maintained itself when you added back testosterone. And you see in the right panel that in the placebo, there was an increase in inflammatory glycans, this G0F, G1, but not in the goserelin plus testosterone. Now, what they then did was to look at what happened when you blocked estradiol by adding anastrozole to it. And in fact, what happened was the addition of anastrozole to the regimen eliminated the protective effect of testosterone. As you can see here in this first panel, there was a drop in the estradiol without the add back, good estradiol. And then when you add aromatase inhibitor, anastrozole, you got complete lowering of estradiol down to very, very low levels. And the protective effect is gone in both placebo and the testosterone group. So it is the estradiol that is effectuating the reduction or maintenance of lower non-inflammatory glycans. And this brings us to the trial that Nina mentioned, which I was happy to be a participant in. It's a clinical trial that looked at the effects of testosterone and metformin on GlycanAge and the IgG glycome. And the goal was to investigate changes in IgG glycosylation patterns and GlycanAge biological age index after 12 months of treatment with testosterone and or metformin. 82 male participants, average age around 40, with obesity, low testosterone, but no diabetes. And they were divided into 4 groups to receive either testosterone undecanoate, which is a sustained release formulation of testosterone, 1,000 milligrams per ml, IM injection every 12 weeks for 52 weeks, metformin, 850 BID for the same amount of time, or placebo. And they had 24, 19, 20, and 19 in each of the groups. And what they found was that men on a testosterone replacement therapy exhibited positive changes in their IgG glycans. They had an increase in these glycan shield, which is an anti-inflammatory component of the IgG glycome. They had an increase in the glycan youth. And then they had a decrease, as you can see, in the pro-inflammatory agalactosylated G0, which is called glycan mature on the report, and a decrease in the GlycanAge. And that was all highly statistically significant. You see those p-values there, but it was not the case for metformin, as you can see in the lower panel. Metformin group pretty much stayed the same. No effect on the IgG glycome, even when it was combined with testosterone. When it was combined with testosterone, but it was mostly the testosterone effect. As you can see, if you look at these decreases in the IgG glycome, it's about the same for testosterone and metformin. These results were validated in patients from my practice, 129 men, average age of 61 now, a little bit older, who are on testosterone at a single time point. This is a cross-sectional study, or metformin, a fairly small number, metformin testosterone replacement therapy, or placebo at baseline. And what they found was that the same basic thing, that there was an increase in the anti-inflammatory components and a decrease in the pro-inflammatory glycan mature component. And as you can see here in the lower panel, that the effect was stronger, and that's likely because in my practice, patients get very good, healthy doses of testosterone to put them in the upper end of the range of normal for a 25 to 35-year-old male, and that increase improves the effect. We see some very significant reduction in GlycanAges, which I'm going to talk about shortly. The conclusions were that testosterone replacement therapy improves IgG glycans, reducing inflammation and biological age in obese men without diabetes. Metformin showed no statistically significant effects except in one individual. That's science. There's always an occasional outlier. And combined TRT and metformin therapy yielded positive changes, likely driven by the testosterone, given that there wasn't a real significant increase or synergistic effect with metformin. So does it happen in case studies? This is some case studies in my practice. Does it happen in real life, in practice? Sure does. I'll tell you, when we first started doing the GlycanAge testing almost 5 years ago now, we first started sending samples in. I got an email back from Gordon Lauc, the chief scientific officer, and was asking me, what am I doing in my practice? Because all these patients were coming back who had been on testosterone replacement therapy for a long time. They weren't baseline tests that were coming in. And they were coming back with their GlycanAges 10, 15, 20, as much as 40 years younger than their chronological age. And he was wondering what I was doing here. And I didn't know I was doing that until I started getting the results back. But this is what happens when you start at baseline. A patient came in, a healthy 46-year-old male. He had reduced response to workouts, but otherwise very healthy. His testosterone was in the low end of normal. Those of you who are not familiar with it, 300 is about the cutoff. Sort of ideal when you're in your bloom of youth is 700, 800, 900, or even as high as 1,000. His free testosterone was actually relatively lower at 55, with the cutoff being 50. And his estradiol, because the testosterone was low, and testosterone's immediate metabolite is estradiol, was actually quite low as well at 13. So we started him on testosterone and enanthate, subcutaneous, 60 milligrams twice a week, which is fairly low, moderate dose testosterone. And this is what happened. He went from 46 to 41. Then he went from 41 down to 39 over the next year. And ultimately, as we got his level up to 864 with a free testosterone 181, which we consider to be pretty optimal, and the estradiol was up, more than 100% to 28 picograms per ml, we had a 20-year reduction in his GlycanAge. And this was accompanied with some improvement in his body composition, his metabolic fitness, but not that much. He increased muscle, but mostly it's because we got his estradiol level up into a more healthy range. I should say parenthetically that in the previous studies, I think one of the reasons there wasn't as robust a change is that the testosterone levels, the replacement was not quite to these levels, and that's why we see these bigger reductions in GlycanAge. Here's another patient who, before we were really savvy about the ills of aromatase inhibition, he'd been a patient for a long time on testosterone and anthe. He gained a little bit of weight because he'd been kind of off his diet, and so his estradiol went up to 80 because increase in fat causes an increase in aromatase activity, which causes an increase in conversion of testosterone to estradiol. And so I put him on an aromatase inhibitor, and what happened was his GlycanAge was at 75. Now, I didn't have one previous to that because we had just started doing them, and I was wondering about that. But then when we learned that blocking estrogen production from testosterone is not a good thing to do in the vast majority of cases, we stopped it, and his estradiol went back up, and he had a 28-year reduction in his GlycanAge because of that, and I think he became much less inflammatory and helped him with his overall aging process. Finally, this is one of those cases that kind of caught our eye when we first started sending samples over to GlycanAge. 64-year-old male physician on testosterone, growth hormone for more than 20 years, regular exerciser, good hemoglobin A1C, high LDL, upwards of 180 at times, but with a good HDL, and a testosterone that ran between 700 and 1500 over the course of these 4 years of measurements, in an estradiol in the 30 to 60 range without any side effects from that. CT angiogram showed 0 calcium and only 4 millimeters of soft plaque, where at 64, you might expect more than that. And that may be because of keeping the GlycanAge so low, almost 40 years younger, or over 40 years younger than his chronological age. And I see this in my practice. People that you think should have it, is this because we're helping to keep the immune system anti-inflammatory, and we know that cardiovascular disease, coronary heart disease, deposition of atherosclerosis is an inflammatory disorder. We don't have the data yet for that, but I think that may partly be the case. Okay, so is this real, and what does it mean? A lot of patients are sort of flabbergasted when I get the results back, and they're like, wow, I'm 20 years younger. Does it actually mean that I'm fully 20 years younger? No, it means that this aspect of your immune system and the way in which your glycans interact with multiple aspects of your body is functioning more like somebody 20 years younger. And I think that there are many benefits that come from that. In my practice, the average females have 15 years younger GlycanAge than chronological age, and males about 25 years younger. Not exactly sure why there's that difference. We do get some women that have been as much as 38 to 40 years, I believe, younger. But we get a really robust, I have some males in my practice that are 70 and a GlycanAge of 25. It remains to be figured out and teased out what this means in the long run, but I think it is going to turn out to be a beneficial effect. And that's when at baseline, they come in pretty much the same as their chronological age. So optimization of sex hormones, particularly estradiol in females and males, has a profound effect on IgG glycosylation. It is less inflammatory. There's less autoimmunity, presumptively, given the association between these glycans I showed you from that big pinwheel and multiple autoimmune disorders, and the fact that complement is activated less when your antibodies are less inflammatory. I think that's absolutely the case. And so I think that going all the way back to the initial question, that we can answer it and say that HRT in women and men is longevity medicine in 2025. I think we have good evidence for that now. Longer term trials will be interesting to see the results of them, but I think that we can, that's the way I present it to my patients. And also, you know, the mantra, unfortunately, is still in women, give it for symptoms at the lowest dose to get the symptoms under control. And that because of the legacy of the misinterpretation of the Women's Health Initiative study, that you shouldn't say that you're using it to prevent cardiovascular disease, that you shouldn't say that you're using it to prevent cognitive decline. You can say that you're using it to prevent osteoporosis because it did show that. But I think that this evidence is quite strong that it should be given. At least they're saying that unless there's a contraindication, there's no absolute reason that you need to stop it at any time point after menopause. And so that's progress. But I think as we get more and more markers, we will see that maintaining a healthy estradiol level, which interestingly is not that much different between males and females, will give you many benefits. Particularly, we're showing here in the immune system, but we measure many other biomarkers in my practice, and we see improvements in those as well. And in fact, from a cardiovascular disease standpoint, there was a decrease in coronary calcium, and there's overall reduction in cardiovascular disease mortality in the youngest group of the 50 to 59-year-olds in the Women's Health Initiative. So that's really the part of the trial that you should be looking at when you're making decisions about treating women with HRT. And from a standpoint of men, I think it's important to maintain good testosterone levels. So what do I do in clinical practice? I measure the estradiol levels, and I correct them for SHBG, or I add a free estradiol. Of course, I'm treating to get rid of symptoms, but a pretty low level of estradiol will get rid of vasomotor symptoms, and a little bit higher can help with genitourinary symptoms. Von der Wright has talked about, the orthopedist, sports medicine doctor that talks about menopause a lot, that the musculoskeletal syndrome of menopause is treated with hormone replacement therapy. And I think, even a little bit higher dose for that. And then for brain, we don't know for sure. For cardiovascular disease, probably 50 picograms per ml. But measuring the estradiol levels can be helpful. And then I get a baseline GlycanAge on all patients. And oftentimes when they're coming in hormone naive, if they're women, it'll be higher. If they're postmenopausal, if they're men, it can be higher. If their testosterone level is low and their estradiol level is low, but you want to get that baseline. And then if I've gotten rid of the symptoms, but I don't see as much of a decrease in the GlycanAge as I would expect, looking using the 400 or so patients that I have on hormone therapy and GlycanAge measurements on in my practice, then I'll consider raising the dose as long as there's no symptoms of estradiol excess. And that will, then I'll try to get it to 15 years younger, 20 years younger. And the way in which the GlycanAge test helps is because even though the estradiol level can bounce around a bit, I think of the GlycanAge as sort of a hemoglobin A1C of exposure to estradiol. And it's not just me thinking of it that way. I mean, that's the way in which it works. It takes about that long, 3 to 4 months for a change in either metabolic fitness, weight, and in particular, hormone exposure to change the glycan pattern, alter the GlycanAge. And so you get a really good idea of what their overall exposure is over the last 3 months. And if it's your numbers have been sort of bouncing around between 30 and 60, and your GlycanAge has come down 15, so it's probably that you're getting a good average exposure over the past 3 months, and you're in a good place. But if the GlycanAge is still not moving down enough, then you might want to raise the dose some. That's how it's also useful in seeing where a woman is in perimenopause. They say there's no perfect marker, and there isn't a perfect marker of where you are in perimenopause. But if you have a baseline GlycanAge and it starts to go up 5 years, 10 years, over the course of the next year or two in your patient, as they're experiencing some perimenopausal symptoms, then it may be time to add some transdermal estradiol, even though they're still having some periods and they're not having vasomotor symptoms because their overall estrogen exposure is low. And so that is my approach. And with that, I will take questions.
Amazing. Thank you, Joseph. That was really informative. We have a few questions, so I'll maybe start with one on how testosterone is connected to increasing estradiol, maybe looking at the whole picture. And also there's some complexity. Estradiol shouldn't be too high in men, and maybe it's a little bit more complex if you have healthy metabolically fit individuals versus metabolically unhealthy individuals, where you might need to have a bit of a different approach.
I mean, look, higher estradiol levels, I think, have been vilified, maybe partly because of the bodybuilding community, where estrogen is bad in men. I mean, like as you mentioned, been practicing for a long time. That tells you how old I am. But in almost 30 years of longevity medicine practice, I've seen a handful of cases of gynecomastia with estradiol, with testosterone replacement therapy. Yes, metabolically unfit men that are quite overweight make more estradiol out of their testosterone, and they get negative feedback. It's so that then they make less testosterone, and the testosterone to estrogen ratio changes. But I think that getting higher doses of estradiol is not necessarily a bad thing. And unless you have gynecomastia or emotional lability, which can sometimes occur, but I really don't see it. I mean, estradiol level of 50, 80, 100, I'm not saying I run them there for a long period of time, but for them to be transiently there, most of them don't see that, as long as they have a good testosterone level along with it to balance that. So I almost never use aromatase inhibitors now to lower that. Weight loss is the treatment for high estradiol levels in the face of testosterone therapy, or even without it. And now we have very effective tools for that. So I'll say, keep the level there for a while. It's not going to cause problems. When you get the body fat down, the estradiol level will come down as well.
Right, we have quite a few more. So there's one on if there's no symptoms of menopause at 50, would you still recommend HRT? And yeah, this is from Pavel.
Well, so it depends what you mean by symptoms, okay? 75% of women in the US will have vasomotor symptoms of some sort. And so you're talking about the ones that don't have vasomotor symptoms, but then there's still the musculoskeletal syndrome of menopause that a lot of practitioners don't really recognize as a symptom of menopause. Just kind of achy joints, frozen shoulder that shows up, knees aching, feeling stiff in the morning. That's because estrogen is very important for making those glycosaminoglycans that help lubricate the joints. So if those symptoms are there, I think it's worthwhile as well. Look, from a osteoporosis, this is the sort of whack-a-mole concept. I mean, once you go through menopause, you start seeing increase in statin therapy, in antihypertensive medications, and anti-diabetic medications, in antidepressants. Why? Because of missing estrogen. Estradiol helps with all those areas. So I'm in the camp that menopause is an estrogen deficiency syndrome. That is not necessarily a disease, because it's universal, but in the absence of contraindications, and that would really just be active breast cancer, I believe that all women should have their hormones replaced to a level that helps their bodies function healthily. I often talk to my female patients that have a male patient that's also in practice with me, and I tell them that a male comes in, their estradiol level is 2 or 3, sometimes 5 times as high as their wife who is in menopause if she's not on hormone therapy. And that's why women catch up to men rapidly in cardiovascular disease and many other diseases of aging. So my answer is, and it's not the answer that all clinicians will give, that it's not just about symptoms. It's about now in 2025 being really a longevity medication, a geroprotector.
And I think this ties to another question on how long should women be on HRT? But I think you alluded to that already.
Yeah, that's a great question. I get it all the time. I have patients come in, they feel better. They're like, wow, I mean, I'm so glad I'm doing this now, but is it a Faustian bargain? Or do I have making a deal with the devil here? And there's going to be problems long term if I keep feeling this good. Is there no free lunch? And, look, the data shows that mortality rates are lower, that if there is any increased risk of breast cancer, it is outweighed by all the other benefits, but I don't think there really is. And we have very good screening tests for it. And women die of breast cancer at a lower rate who are on hormone therapy than women who are not on hormone therapy. So that's another thing to keep in mind. So, I will tell you that I have a 99-year-old patient who has been on hormone therapy her whole life. And that may be part of the reason she's 99. So I don't think there's any absolute reason to stop it. And that's actually the official position of even some of the conservative menopause societies. If there's an indication for it, then continue it. Absolutely have that conversation about the unknowns, about, absolute numbers for the risk of certain chronic diseases of aging after 25 years. But you try getting some of these women off of it. They just don't want to feel that way. I do suggest it, and some of them do go off for a bit, but then they come back on.
We got a suggestion to remove the share screen. Sorry, we're not.
Okay.
Let's see how to do it. Oh,
Okay.
okay. Yeah, they want to see you better. I think that's better. There's an interesting one saying, how do you explain that 99% of centenarians have never taken hormone therapy, and yet they have extreme longevity?
Yeah, because they have some great genes that are trumping the lack of estrogen. Jeanne Calment, the oldest living human to 122 years of age, smoked and drank every day and never exercised. Okay. Would she have lived to 140 if she hadn't smoked and drank and started exercising, or 150 if she had been on estrogen replacement therapy? It's possible. The genotype of extreme longevity helps you to stay to get to extreme longevity, and it's really not. That's not an argument against the use of hormone therapy in somebody that doesn't have those extreme longevity genes. I mean, look, it'd be nice to have those genes, but people don't. Very few people do. And what we have is the average genotype that responds very well to long-term hormone therapy.
And I think that makes a lot of sense. There's a recurring question around what other things affect GlycanAge beyond HRT. Of course, HRT, TRT is used in your practice as a standard if there's an indication for it. But have you noticed anything else that would move the needle?
Yeah, I mean, so I think that I mean, there's a lot of data for it as well. Metabolic fitness, visceral fat, increasing inflammation, sedentary lifestyle, high blood pressure, high blood glucose, diabetes, all those things will increase your GlycanAge. I can tell when patients come in that have that phenotype, so to speak, that they have higher GlycanAges than my sort of relatively fit patients that come in. So those do affect it. And then also, I will sometimes get people to a very good GlycanAge with hormone therapy, but then I'll see it drop even further when they've added more exercise, shed some pounds. So there are many things that affect the GlycanAge, and we're learning, about more and more of them. But as profoundly as raising estradiol levels, I wouldn't say there's too many that do that. Increasing IGF-1, I think, probably does improve the glycan S and glycan youth. That's just my clinical anecdotal observation. But and testosterone may have a beneficial effect that may not. I mean, it's possible when you add it to estrogen in females, but I don't know for sure.
We don't have those studies yet, same as we
No.
don't have the long-term data on men. And I think that's what we're trying to find, these surrogate biomarkers. So maybe I'll give you my question. because there's also the PhysioAge platform, the software tool you created to track, I think, over 700 different biomarkers that you look in all of your patients. What are those other key markers that you notice improve as they join your practice that gives you like a surrogate endpoint for what's going to happen in the long term?
Well, you know, while I haven't looked at it systematically, there is data to show that and Morgan Levine published on this, that epigenetics will improve, your epigenetic age will improve on hormone therapy in women. I don't know that there's data in men. We do see improvements in skin elasticity with it in both men and women. We measure skin elasticity with a highly validated instrument called the cutometer. Central arterial pressure, probably through peripheral vasodilation, occurs with hormone therapy, a reduction in central pressure, which is what we call our cardio age. We can see that that may be through improvement in the glycocalyx, through improvement in nitric oxide. Not 100% sure about that. We have a lot of further analysis to do of our database, but those are the kinds of things that I see in individual patients.
Now, there's a few specific ones, but one is on how often do you adjust the dose of HRT? And then there's addition to that, do you discuss the, that foods, fasting to support the estrogen, or how you don't pronounce it that way, but
Estrogen, yeah.
Or the detox pathways to improve hormone metabolism. And I guess this is going to the excess testosterone theory in women.
Yeah, I mean, what was the very first part of the question again?
How often do you adjust?
Oh, yeah, right. So I adjust as often as necessary in terms of symptoms. Sometimes, you can have a woman on a stable dose or a man on a stable dose of any hormone therapy, testosterone, estradiol, growth hormone, et cetera, and just changes in their diet, changes in their microbiome, how much exercise they do, body composition can change their serum levels and the response to the hormones. So I do it in response to that. The microbiome is important for estrogen metabolism because estrogen has enterohepatic recirculation. And so when there's changes to the microbiome, I don't specifically target the microbiome because I'm not an expert in that area. And anybody can contact me at Raffaele MD on Instagram if they have an interesting way that, or clinically can see how they can manage hormone therapy through the microbiome. But I will respond by changing doses if there's estrogen excess or testosterone excess symptoms, or if I'm again using the GlycanAge to changing my hormones to change the GlycanAge that I have, if to improve it further or to bring it back, that sort of thing. But I'm again doing all sorts of things like having a diet high in fruits and vegetables, high in fiber, to have a healthy microbiome, so you have healthy estrogen metabolites is definitely an important thing, but I'm just not sure how well we can do that yet with microbiome testing.
Understood. And then there's a question of bioidentical hormones. Are they preferred?
Always bioidentical hormones. I mean, you have to take the wisdom of evolution, and these hormones are there's receptors in every tissue. So you want to use a hormone that your body knows, that's been in there, an endogenous hormone, which is the scientific name for a bioidentical hormone, a hormone that your body is used to having, is important. That's why, the Women's Health Initiative was not probably as good, is because they weren't using bioidentical ones, particularly the progestin, which we know has increased risk of cancer with it, medroxyprogesterone acetate. That all being said, with regard to estrogen, any estrogen is better than no estrogen when it comes to menopause. And so that's why they did get beneficial effects, particularly in the Premarin only arm of the Women's Health Initiative. But I do absolutely prefer or exclusively use bioidentical hormones because of how they're metabolized and how there are so many receptors in the body for it, that you want to use the hormone that the body's used to.
So there's one on safety of HRT over age of 60 and dose, and if you should be taking down the dose with age.
I think that, as I alluded to earlier, that while we don't have long-term data, we have the Dutch osteoporosis, the Denmark osteoporosis study looking at 22 years of hormone therapy, no increase in mortality, some decrease in mortality, no increase in breast cancer. There's some data, some studies show a little bit of increase at long-term hormone therapy. So I think that, you have to look at longevity medicine should be N of one, personalized, tailored medicine. You have to look at family history. You have to look at many different factors and come to a consensus with your patient about the risk-benefit equation. And so have that conversation with your patient, but I absolutely do not think that after 10 years, you have to stop. It makes no sense physiologically. I don't think the risk goes up enough to counteract the benefits. The benefits continue and only continue if you stay on it. The bone benefits, the brain benefits, the cardiovascular system benefits, and now we know with the GlycanAge, the immune system and anti-inflammatory benefits, they continue as long as you're taking the medication. And breast cancer, look, breast cancer is, I don't want anybody to have breast cancer. My mother had breast cancer twice and she was never on hormone therapy. She did not die of breast cancer. She died of Alzheimer's disease. She might not have died of Alzheimer's disease if she had been on hormone therapy. And so, you want to look at the whole picture and make a decision with your patient. But in the vast majority of cases, staying on it, and particularly if you're following markers of bone, of arteries. I have patients, women who are 75 years old, who've been on hormone therapy for 25 years, have run LDLs of 200, total cholesterols of 300. They don't want to be on statins. I think they should be on statins, but they don't want to be on statins. The cardiologists are like, get off the hormone therapy. We did a coronary calcium and they have zero calcium in there. So they have no atherosclerosis. That is the estrogen protecting their arteries. And I think that's one of the main things we need to do.
Excellent. Now, one that's specific to the breast cancer case study, can an estrogen patch be given to a patient who had, I think this means a double mastectomy and no uterus, but had a history of breast cancer 10 years ago, and now has symptoms of menopause? I think you answered it already, but maybe you can.
Well, so the official position of the Menopause Society is that they shouldn't necessarily, but I think there's other societies that believe that if the symptoms are debilitating, that in completely informed consent with the patient, discussing the pros and cons, that you could do it. I do treat about 5 women who are survivors of early stage breast cancer. I've waited 5 years from then. We follow the GRAIL, we follow mammograms, we follow them closely, but it's their decision that, it's the benefits that they get in quality of life outweigh the risk. But it's after a very long, detailed conversation with the patient, with their oncologist. And I've had oncologists be on board with it if the patient's symptoms are bad enough.
And there's another one for dose of estrogen in mid-40s. So healthy women in mid-40s, what would be the recommended dose? I guess this.
Yeah, so I assume that the patient is, just early perimenopause. Does she need it? The answer is we don't know. If she doesn't have symptoms, then probably not. But again, in that case that I alluded to, where a woman is starting to feel maybe some slight musculoskeletal symptoms or word finding problems, before the period when estrogen levels are dropping precipitously. And if you find that her GlycanAge has gone up 5-10 years, then, low dose patch. I'll often put a woman who's still cycling. She doesn't need any progesterone on a 0.0375, sometimes a 0.05 patch, so she doesn't drop low, and to keep her GlycanAge in a reasonable range. I don't have enough cases of that yet to say how well it works, but theoretically, you could keep a woman from ever increasing her GlycanAge if you monitor them closely like that and you have a good baseline. And I think that's where probably where the standard of practice is going to go eventually.
Yeah, so you can technically prevent all the symptoms or the
Right.
severe.
You prevent all the symptoms and the initiation of any of the stuff. And that's what you really want to do in a longevity practice. You want to maintain as healthy functioning of every organ and system as you can for as long as possible with a good risk-benefit equation.
And I think that this is a complexity with how HRT is prescribed, because on the label it says post-menopause, and menopause is a retrospective diagnosis. So it's
Well,
really
yeah,
the
I often see patients that come in and say their doctor won't treat them with hormone therapy because they're not through menopause yet. And I'm like, they're having hot flashes and night sweats to beat the band, which many women do in perimenopause. I mean, that's crazy. You get started when the symptoms start. And that happens when the estrogen levels start to drop. Yes, it can be a roller coaster where sometimes the estrogen levels are very high. And so you have to, tell them to take the patch off. If you have breast tenderness and no hot flashes, you take the patch off until the breast tenderness goes away. And then the next cycle, which might be no estrogen, you need to put the patch back on again. But maintaining good estrogen levels is important.
Now there's a few more, there's one specific and then a few more on TRT. Now we're a little bit over time, but we still have quite 60 plus 65 people in the audience. Are you keen to go 5 minutes over?
Let me just check one second. Yes, I have about 10 more minutes, probably. Sure. 10 more minutes, or whatever you need.
We won't keep it too long, but yeah, let's go a few. Otherwise, we'll answer a few questions on email. So there's a very specific one on, well, there was one that just went missing, but on what do you mean by correcting for SHGBs or the sex binding?
Sex hormone binding globin. Okay, yeah. Sorry about the lingo. So your estradiol level, the active effective estradiol, is the free estradiol, and that's a very small proportion of the estradiol. Sex hormone binding globulin carries estradiol and other sex hormones around in the blood, and if your binding globulin is very high, so normal is like 60 to 120 in a woman. On birth control pills, it can go high as 250, 300. And that tightly binds up the hormones because estrogens, when they hit the liver, cause an increase in sex hormone binding globulin. So, that's why you can talk about estradiol levels, but if there's a woman that has an estradiol level of 50 and her SHBG is 120, that's much less estrogen exposure than a woman who's got an estradiol level of 50 and her SHBG is 60. And so the free estradiol corrects for that, but you can correct for it by sort of just doing the math on it. If it's a high SHBG, then you have to say you're getting relatively lower estrogen effect. So that's what I mean by that.
All right, a few more. So there's the same question for men. If you have healthy men in his 40s, what would you put them on if they want to stay healthy? So preventatively.
Testosterone?
Testosterone, yeah.
Yeah, so this study that we showed, the testosterone level when they first screened for them, the first study, they had testosterone levels by the chemiluminescence assay under 300, but the LC-MS-MS, which is the gold standard now, was a little bit above 300, 350 to 400. And there are a lot of men who are in that range who are technically not hypogonadal, meaning below 300, but who have symptoms. And in those men, I do a questionnaire called the Q-ADAM, the Quantitative Androgen Deficiency of the Aging Male, which will give you a score based on symptoms, erectile dysfunction, libido, energy, recovery from workout, sports performance. And if they're in a range where it shows they could have low testosterone on that, and they have a lowish testosterone, then a therapeutic trial of testosterone is warranted. And that's, in the literature as well. Shalender Bassine, a big testosterone researcher, has done that work. And he agrees that even if you're in the mid 400s, you can, particularly if that mid 400s is associated with an SHBG that's high, which can happen as men get older, so its effective level is much lower, that you put them on it. If those symptoms improve or go away completely, then you've done the man a favor, and likely you've improved his GlycanAge.
Amazing. Now, we have four more, and then we set you free. We'll try to make it quick. Now, this very specific. Have you ever had a case where 1 year of TRT therapy increases T to 1,100 plus, and then at 12 months knocks estrogen level to near zero? Very specific.
Well, no, I don't. I mean, no, that shouldn't happen. If your testosterone is high and you've not added an aromatase inhibitor, then the estradiol level should go up along with the testosterone, because as testosterone levels go up, there's more substrate for estradiol, for the aromatase, to turn testosterone into estradiol. So I haven't seen that. The only way you would see that is if they're on aromatase inhibitor. And assuming they're getting testosterone replacement therapy, then that shouldn't happen except with the aromatase inhibitor. I should also just say about men and total testosterone. I have patients come in, 75 years old, symptoms of low testosterone. They go to their internist and they does the testosterone level, and it's 1,000. And definitely see this. Their SHBG is 150 though, and their free testosterone is under the normal range. And the internist won't treat them or refer them to be treated because they haven't done the right test, which is a free testosterone. And their estradiol level is going to be low. They could even have some hot flashes because their estradiol is so low. That man needed to be treated. You cannot use the total testosterone to make a decision about testosterone therapy in an older male.
Now, one on if somebody has higher muscle mass, will they need higher estrogen levels or more estrogen receptors? Okay. Confusing.
Don't.
Oh, so okay. It's basically if you have higher muscle mass, does that mean you need more estrogen?
I don't think so. I actually don't know the answer to that. I don't know that there is any data that speaks to that, honestly. When we say need more estrogen, from what standpoint? You only need, from a symptom standpoint, enough estrogen not to have, vasomotor symptoms, which men get if they're on a GnRH, which knocks out their testosterone if they have metastatic prostate cancer. But otherwise, the amount you need, now we can think about it in terms of GlycanAge, but otherwise, yeah, it's hard to know what the person's trying to get at there. But I look at an estradiol level to be in the 30 to 50 range. It can be lower in a younger male because their SHBG is typically lower, so the total estradiol will be, a little bit lower, but still the free estradiol will be good. But even if it's as high as, 60, 70, if they have no symptoms, then I'm not as concerned about it, particularly if the GlycanAge is in good range.
Okay, the end of that question was also as a similarity. If somebody is overweight, they maybe need less estrogen, but yeah, I think maybe let's skip over that one if we didn't answer it.
DM me on Instagram if you want to ask the question again.
We can follow up on them on email if we didn't catch something correctly. Now there's one on insurance. So US insurance, does it cover HRT for, well, I guess HRT or TRT for men and women? It's confusing because it says for men and women, but if they're out of menopause. So if it's not in the transition, but they're, let's say, 60.
Yeah. I mean, for women, yeah, they don't, I mean, I don't do much insurance stuff in my practice, but my understanding is that it's not that they stop covering it, although I suppose that could be the case. But it seems like the patch on most people's insurance continues to be covered, or, I often use compounded as well, and that's not covered by insurance often. But if they're on traditional patch or gel, estrogel, something like that, then it's not, they don't stop it in postmenopause, stop covering it. I think my 90-year-old or 99-year-old is still getting it covered.
Amazing. That's it. We're going to let you go. Maybe the last thing for the audience is where can they find you? If somebody...
Well, you can find me on Instagram at Raffaele, Raffaele MD. And also I have a website for my software company, PhysioAge.com, PhysioAge.com, and RaffaeleMedical.com is my medical practice if you want to become a patient. And there's a good website there for where I blog fairly regularly, once every couple of weeks, on topics of interest. post on Instagram fairly regularly, and answer my DMs. So happy to interact with you.
Thank you for your time. That was incredibly insightful. Any follow-up questions, you can email, and we're going to share a recording with everyone.
Great.
And there was a question on slides, so maybe you let us know if you're keen to share the slides, or if
I think I can send PDFs of the slides to you. Sure. It's a little bit complicated with this slide deck, though, because there's a lot of fancy animations in there that I can see if we can do it so that the animations are not kind of making it hard to look at. But or you can my tech people, which is not me, will try to work that out.
yeah, we'll work it out in the background.
Okay.
Amazing. Thank you for your time. Thank you for everyone for joining. And yeah, we'll see you
You're
on the
welcome,
next.
Nina. Take care. Talk soon. Bye-bye.
Bye.